who presented with epigastric pain for last 3 to 4 months. There is no history of weight loss or jaundice. CT showed dilated CBD of 1.4 cm at the region of pancreatic head and mild to moderate dilatation of intrahepatic ducts. Pancreatic duct is also dilated of 3 mm. There's abrupt narrowing of distal CBD, and also there's a smooth circumferential mural thickening encasing distal CBD at the region of ampulla. LFTs are normal.
So I mean, one of the things we're supposed to do is discuss your objectives for this.
Yes. So, Doctor, hello. Can you hear me?
Yes.
Mustafa, can you hear me?
Yes. Can you hear us?
So, yeah, we can hear you and see you clearly. So, this is an ampullary mass with dilated ducts, but no derangement of LFTs. Correct?
Yeah, I think suspected ampullary mass, right?
Suspected.
Yeah,
Okay.
exactly. So, okay, just give us a minute. So, your primary purpose is what?
My purpose is to,
In this case.
is to just to one thing is that we have to confirm whether there is any.
वो तो ठीक है, but like from a technical standpoint, what would you like to do?
I want to do.
You want to pass the scope. You want to look at the mediastinum. You want to look at stomach. Like what do you want to achieve in this case?
The main thing we want to. The main area of our interest is the T2 area.
Sure.
Where we have to first of all confirm the.
ठीक है.
I don't know whether the gentleman EUS will be there, whether taking the biopsy or not.
Right.
We did the EUS to see the extent of the disease.
Say.
And meanwhile, if you take the biopsy from this, we can.
Sure. But इस केस में आप क्या सीखना चाहेंगे? आप मतलब वो तो है. We want to assess that. But आप what do you want to get out of this case?
Well,
Pass the EUS scope. Look at the pancreas. Look at कोई specific चीज़ है या you want to just try a bit of everything?
Yeah, one thing is that try a bit of everything because I'm totally new.
Okay.
But if I'm
So my suggestion would be the easiest is the stomach, right? The stomach views. I think, and you obviously have a lot of experience with ERCP. So I think I would be comfortable with you putting the EUS scope down and advancing it into the esophagus and into the stomach. From there, I will take over and identify the structures, and then I can hand it back to you, and then you can identify the structures as well. Okay? So first thing, always what you want to do is, I think Dr. Khalid mentioned this too. My preference is I always like to test the balloon myself. Make sure that there aren't any bubbles. Oftentimes there will be some small bubbles, and if you just shake it like this, they'll come up to the top. And then the port for the suctioning is right there at the top. So those bubbles will go away. And if you want, then you put the scope back upwards and put the balloon up again. Make sure any bubbles come out. Now I don't see any bubbles. Again, I'm going to shake it, suction, and now my bubbles are gone. उसके बाद ये है कि पानी है, even though we've tested the suction, you can always test it again in the water. Just so this, make it a routine every time. I noticed that people hold scopes different ways. I think Khalid was holding it like this. I think Dr. Saad also holds it like this, at least for ERCP. Meri training and my preference is actually to have the hand on the other side of the umbilicus. So I actually hold it like this, and I don't think there's a right or wrong way, but this is how I was taught, I learned. It actually, if you're not used to it, it makes a difference. So for me, this actually makes a difference. I feel the unnecessary pressure on my wrist. Some people say that it supports the scope on your wrist, so it actually protects your wrist. But for me, I've been doing it like this for years, so I just find that. In terms of setup, I actually also have it like Dr. Khalid, where I usually have it behind me, but then I have my EUS console in front of me, so there's a slight difference. Here we will work with this. तो ये है. उसके अलावा you check the air water. Sometimes in EUS I will actually turn my air down. Up to we've switched over to CO2, so I use CO2, but you don't need too much air in EUS. So I will actually, when I used to do air, would have my air at the low level, and then start. So I'm going to let you. It's similar to ERCP. It's not a forward viewing. There is a bit of a gap. ये जो distance आप देख रहे हैं from the lens to the tip is about 2 centimeters. ठीक है? So I think because of your experience, I feel comfortable with you advancing, or फिर we'll go from there. Gently, बस आराम से. There you go. Excellent. And as soon as you're through, again, different people have different approaches. My goal usually is to get past the GE junction through this esophagus, and then so keep going. And as you know, the G junction is usually around the 40 mark, right? So it's going to be somewhere there. So you keep advancing. Okay. This may you do have EUS as a guide too, but you should try and see it endoscopically if you're faster. So yeah, this is very common. You get into the stomach and you start hitting the back wall. The less. Isme what you do is you extend the big wheel away from you. Extend and drop your left hand.
Hello?
Yes.
Yeah, थोड़ा सा mic अपने करीब कर ले मुस्तफ़ा.
Sorry.
Ask them to just do that so that we can hear you more clearly.
Sorry about that. Yep. ठीक है. ठीक है. शुक्रिया. चलिए अब let me take over for a minute and then मैं आपको फिर बाकी we'll discuss a few things. एक चीज़ ये कि you want this distance and you want to support it like this. You don't want to hold it too close to the mouth and too tightly because that restricts your mobility. If you do it from here, your hand is free to move around and you can watch clear. यार ये light थोड़ी सी कम कर सकते हैं, like पूरी ना ऑफ करेंगे कि वो उनको नज़र नहीं आता, but और कोई लाइट है इस कमरे में या नहीं? ट्राई करेंगे. इस साइड पे नहीं है कोई लाइट? चलें फिर ऑन कर दें, कोई नहीं. I actually like to have my room about as dark as it is right now, but for transmission purposes, obviously this won't work. तो आप ऑन कर दें, कोई एक जला दें. ये तो ज़्यादा हो गई ना. चलो ठीक है बस. तो anyway, so the first thing is जिस तरह आपने किया कि you get through the G junction, you drop your hand. If you drop your hand like this, you can see the stomach. To the left will be the fundus, right? This way. To the right will be the antrum, just like ERCP. Yeah. But it allows you to get across this area where you're getting hung up when you first come in. So drop your hand. My approach is slightly different from what you've seen. I usually go in a bit, go clockwise, have my thumb down, big wheel towards me, and I'll usually have pancreas here. So as soon as I see pancreas, I will actually start going clockwise, come back to aorta now, and basically identify my aorta this way. Once I have my aorta, I have my up at the screen, I'll have the crest of the diaphragm. और मुझे जो है, I don't like to have half the right up here. I don't like to have the lower half of the screen not showing me anything useful. So I actually like to make my image more magnified. Isme we do lose some resolution compared to the machine that I typically use, so we may go back out a bit. EG. हाँ ज़रूर दिखाएं, of course. We're going to switch you over to the other room because they have a lesion to show you. तो उसमें ये होता है कि then once I'm here at the aorta, I will basically keep it in view and then look for my celiac and SMA. ठीक है? Once I have the celiac, then I'm going to have एक चीज़ याद रखिएगा कि you have to have some thumb down to keep the probe against the structures. अगर आप थंब रिलैक्स कर देंगे तो आपको चीज़ें शायद इतनी क्लियर नज़र ना आए. तो थंब डाउन करके यू सी दिस सीलियक टेक ऑफ और वहाँ से इफ़ यू कीप टर्निंग क्लॉकवाइज तो यूजुअली यू विल सी इसको थोड़ा सा और आगे बढ़ा के सी तो आपको एड्रीनल ग्लैंड यूजुअली नज़र आ जाता है राइट अबाउट देयर. So that this so clockwise and then you have adrenal.
Adrenal is hypoechoic.
Hypoechoic, exactly. यहाँ पे we're getting air from the fundus. You can always put up your balloon, and if you put up the balloon, you can get rid of the air artifact. So ये हो गया adrenal, and
So right now you have inflated the balloon or not?
just a bit, yes. Right, this
How can
here.
you know that your balloon is inflated?
So you see the black. So that is the probe, and that black is the balloon, water in the balloon, and there. And if you want, you can look endoscopically too. You can see it slightly up, right? So those are the movements that I typically do to get to the celiac, and then the branches of the celiac. Once I have done that, I will just gently advance again, like before. Go clockwise. You have the liver here, the left lobe. And as you keep turning, you'll land on the pancreas.
पहले मुस्तफ़ा
Now
को
that
ख़त्म
you
कर
have the
लेने दो
back-
फिर उसके बाद इधर
So you have the liver.
नहीं
so
मैं कह रहा हूँ
down.
कि उसको तो पहले काम कर
the-
लेना कर लिया है वो आपने या अभी वो बात कर रहे हैं ना
I went in. I actually just let me repeat.
क्या लग
इधर
रहा
से
है
आए हैं from G junction. Drop my hand.
की लग रहा है
Advance 1 second.
कुछ ट्यूमर लग रहा है अच्छा मैं देखूं उसको एक मिनट दीजिए ज़रा पकड़ना अभी इसको कुछ नहीं करना मेरे भाई है क्या सारा इधर कैंसर लग रहा है
हाँ जी एक सैंपल ले लो
नहीं सैंपल तो और ले लेंगे डेफिनेटली लेकिन ये तो कैंसर लग रहा
हाँ जी लग रहा है जैसे चाहिए
Khalid,
है सॉरी जी
we can hear you.
Oh, I'm sorry. I didn't know if you can hear me or not.
Yeah, we can hear you, and now we can see you as well.
So I went to take a look at the slide actually.
Yeah.
And we have a diagnosis there, but I need one more sample. Is Mustafa done? Let him finish and then I can do it. Or what's the...
No, Mustafa might take he's got a normal system which would be very good to go back.
Okay.
How long would it take for you to like show what you wanted to show us?
So it's just going to take a few minutes.
Okay, then let's-
So
let's-
maybe 2-3 minutes.
Okay.
So I'm going to go straight to what I want to show you. So we really don't see much of that, but you might see more here in this part of the word. So here I'm in the antrum. And
Yeah.
do you see this structure?
Yes.
Anybody wants to guess what that is from the audience?
So what is this?
I'm in the antrum and I'm
So
looking
they're
at...
saying gallbladder.
And what do you see in the gallbladder? Is it a sludge or what is it?
They're saying sludge.
Okay. So
It's actually
it's a... Now what I'm going to do, there is a sludge too, but it's kind of really organized sludge, right? Not even moving at all, you see? So what else it could be? Here, look at that. Not
so they're
moving at
saying
all.
it could be mass.
Yeah, so it really is, I think it's a mass. And with the gallbladder, what you can do really is you can do a FNA, but you have to be a little careful due to the risk of bile leak. You want to use a 25 or at the most a 22 gauge needle. Try not to use a core needle and just get a FNA needle. So here Look at this, like there is some sludge component too, but when I shake it, it really doesn't move. It's just right all in one place. So that's one thing I want to show you. Let me show you how I'm going to do the FNA of that.
Khalid bhai,
Ji.
I can appreciate a very well-defined wall and the intraluminal mass interface as well. So if it is arising from the wall, shouldn't it be a disrupted mucosal lining? Because I can see a very clean hypoechoic rim between the wall and the mass, if it is a mass. There is no wall disruption.
So no, I don't see a wall disruption
Yeah.
either.
Yeah.
So, but here, if I go around, right in this area, it looks like it's maybe really close. But let me show you what I think where it's arising from. It may not be arising from the lumen itself, but I'll show you in a minute, just a minute, like where I think it's arising from. I think it's arising from the neck area and going into the lumen. Is there a section there? And when you start doing FNA, if it's really a sludge, that will just spread out. But this one is not spreading at all. And it's maintaining its shape.
So can it be a sludge ball? When
You
it
can see
starts
a sludge ball like that, but we are getting a cancer cells on this. I already made one pass. A well-formed sludge ball can look like that, but this is moving around. It's not really attached to the wall itself, but I don't think it's arising from the lumen itself. It's involving the cystic duct and also involving the neck of the gallbladder. I'll show you in just a second. Let me just make a FNA
And
here.
Khalid bhai, has it engulfed few calculi as well? Because I think there are few calculi engulfed.
Oh
in
no,
the
no,
mass.
definitely. There is actually a one big stone. So there are calculi too, but this looks.
Khalid?
Ji.
Cross-sectional study में what did they show? Because we don't know otherwise about the case.
जी?
So it was a CT scan
क्या
done?
CT scan पे gallbladder mass था या bile duct? Suspicion of gallbladder mass.
Okay. Because to be honest, if I had no CT information on this one or suspicion, and I just saw this, I'm just wondering whether, I mean, your experience is obviously very, very big, but that little lump and swelling that we saw in the antrum, that is something that you don't generally see, and I don't know if that's hard, that would, but
So
otherwise
that- as soon as
I'm
I
impressed
saw-
that you could.
As soon as I saw that swelling, I knew it's coming from the gallbladder.
Yeah, that I see, but we don't see it that often with the gallbladder mass here.
Okay.
That's what I was.
So what I'm going to show,
So I'm
like
impressed that you thought.
give this to Wasim, and let me show you one thing, and then we can go back to Mustafa. Let me get into the duodenal bulb, and here you can see I'm right into the duodenal bulb right now, and you can appreciate the bile duct right there, right? And there is a portal vein right here. Do you see any problem with the bile duct?
Yeah, the walls look thickened here.
They quite look thickened, right?
Yeah.
Quite thickened right here,
Yeah.
and all the way pretty much to the ampulla. So I don't know if it's arising from the bile duct and coming like it's involving the bile duct as well. But one thing what I want to show you, I'm following the bile duct towards the liver right now.
We're going towards the liver.
Towards
is
the
there.
liver, and here you see the bile duct is still here. Do you see some structure right above that?
Yes.
That's a cystic duct.
Oh, okay.
So the cystic, look at the cystic duct. I'm
Yeah.
going to follow that, the cystic duct, following that. Keep an eye on that. You still have it. You see that it's ending up
Mass.
into the gallbladder right there. That's where the mass is arising, I think.
Excellent.
Okay. So this is what I wanted to show you. And the sludge ball absolutely can look like that. But here, few things which are giving me a clue, the way the cystic duct looks like, the way neck of the gallbladder look like, there is a stone, big stone there as well. And when I do a FNA of that, this could be a very nice, well-formed sludge ball too. But a combination of different things, the way it's going in there, the way the cystic duct looks like, and I'm doing a FNA of that.
So-
and still
so-
the sludge ball is not breaking up.
Khalid,
G.
so the possibility of cholangio is also there with the
It
thickening
is.
of the bile duct, and you can literally trace it all the way.
Yep.
And
Absolutely.
then the cystic duct as well. So
Absolutely. Okay, so this is what I want to show. So we'll,
that was excellent, Khalid. Thank you.
we will finish it up, and you guys should go back to Mustafa.
Very well demonstrated. Thank you.
जी इस पे ज़रा देखो बाकी मैं
Mustafa, we are back with you.
Okay, so we just evaluated from the stomach and the bulb, and I'll re-demonstrate that. And we just came to the second portion. So obviously the concern here is a possible ampullary lesion. You have the endoscopic view as well?
Yes, we do.
Okay,
We have the endoscopic view, and we have the room view as well as the EUS.
Okay, so just looking for the endoscopic view, I don't see anything obvious here.
Yes, clearly.
Sometimes where the papilla is not obvious, you can get a biopsy forceps, and with the elevator you can just lift the fold out of the way. So my typical approach is I look at it endoscopically, put up my balloon a bit, and then I will bring the thumb, the big wheel close to me. And this is what I was saying earlier in my talk, that here I will usually now turn my body clockwise so that I'm basically facing that corner of the room. And here I will go, if you look at my hands, the scope will be bent backwards. My right hand is supporting the scope, and I will gently start going clockwise and counter as I pull back. So I'll do this movement, pull back a tiny bit, go counter, start seeing pancreatic structures, but not keep
So
going
that's
counter.
one of the ducts coming there.
Yeah, but I'll still go clockwise again to look at the unsnit. Now
Do you see a lymph node as well?
I do see, yes, a lymph node there.
Yeah, there. Just there. That's a lymph node there.
So this would be the lymph node there. And then basically I will keep doing that till I have the ducts in good view. So counter, and now we see a duct in the upper right corner of the screen. So this could be pancreatic duct or bile duct. It looks like pancreatic duct. So I'm just going to gently withdraw the scope some more. Look at the duct. And there's the second duct. So clockwise, I use the terms clockwise and counter, but in this one I guess it would be right, would be towards...
Clockwise and counterclockwise is fine.
Okay, so clockwise for anterior, and as I go counterclockwise, I'm going more posterior, and the first duct to come into view would be the pancreatic duct. And if we measure that, it clearly is
Is
like
that-
almost like a snake's head kind of view
Yeah.
of the duct, and it's going to be dilated. So
About
it's 5.4
5 point something.
millimeters. And I'm going to actually just increase my depth here. So then I'm going to keep, now I'm going to go counter, and there's the takeoff of the bile, or the start of the bile duct. So now I'm just going to gradually relax my big wheel and keep pulling back to see what's going on.
So the bile duct doesn't appear to be dilated.
Here it doesn't, but if we look, when we looked at it from the bulb, it sure did.
Okay.
So now the question is, could there be a subtle ampullary lesion that we're missing?
So this is your pancreas and this is the uncinate.
Right, so one thing you can do in this situation is, if you really want to get a more accurate evaluation of the papilla, is to actually, at this point, distend the duodenum with water. That will move your duct, your probe, EUS probe, away from the duodenal wall. And with that distance, you can very accurately measure accurately assess the ducts as they open into the duodenum. The other thing to do is I had a fair amount of big wheel towards me, so compressing that area. So I've relaxed my big wheel and I'm just trying to study as the ducts come in. So there's the PD coming into the duodenal wall. And I just want to point out here that this is a side branch of the pancreatic duct coming towards the unsnit. This is the boundary of the pancreas, and this is pancreas unsnit. There's PD, and the PD will go into the duct here. So as you can see, it's like a bird's beak. It tapers in, but there's no discrete mass lesion that I can appreciate on these views. And you can see the branch to the unsnit coming off the main duct. And then as I go counter here, we should start seeing, there's some air artifact, but we should start seeing the bile duct, which is at the top there. This could be a vessel, so just to be sure I'm not mistaking a vessel for the duct, wrong one. Put flow on, but you see the middle one has no Doppler flow, so that's the bile duct. So now we're just going to keep following the ducts. I feel like the bile duct's getting pinched because it does become dilated higher up. So I'm going to relax my big wheel some more and see if I can go counter, but I just fell in that process. So at this point, I'd like to follow the pancreatic duct all the way. फंस क्यों ना है? इसमें लूप थोड़ा सा दिखाइएगा. Back into the second portion, get my pancreatic duct view again. So there's the papilla. Again, studying it endoscopically, nothing remarkable. Back in that second portion view and going counter from there's that little node again. I ordinarily would not sample that node. I don't know what your thoughts are.
Agree.
Pancreatic duct, aorta, so I need to pull back a tiny bit.
Can you just show the aorta and the inferior
Right.
vena cava again if you possibly can?
Yeah, so aorta and then IVC. But it's getting compressed by the scope. But this here is aorta
IVC
right there, and you can see the walls are distinct here, and we can always do the
This is aorta.
Doppler flow, and then वो pulse वाला
उसके बाद थोड़ा
pulse
सा और
wave.
अगर if he goes that way then we just saw the IVC. No, so now we can, he's going to put pressure, power Doppler, and that power Doppler will tell us whether this is RE.
Yeah. And this is what Khalid was mentioning about the waveform. This is an arterial waveform. Just like an arc line, basically it shoots up and comes nice down quickly.
The sound with that
And you can increase the
gas
volume on this. Sample volume.
आवाज निकलेगी तो फिर दूर करेगा.
जी.
वॉल्यूम बढ़ाना
वॉल्यूम कैसे बढ़ाते हैं?
हाथ वॉल्यूम बढ़ा
ये ना. So I don't know if you can hear that or not. Anyway, so that's. Are you with us?
Yeah, sorry, Mustafa.
कोई बात नहीं. Yes.
आपने कुछ हमसे बोला?
Hanjini, I was just showing you the
Yeah,
arterial waveform.
we saw the power Doppler very clearly.
Okay, and I don't know if you can hear it too, but that's okay. If you can't,
No, we
that's
can't.
fine.
We can't hear it, but I think.
The principle is demonstrated.
Yeah,
right?
yeah, yeah,
Okay.
yeah.
Okay, so that's
So can you
Mhm.
go back to the inferior vena cava a little bit?
sure.
So now you're going to go anti-clockwise or counterclockwise. Keep going that way, and you'll get the inferior vena cava. Correct?
Yeah. Sorry, I have pancreas, so I'm gonna go.
So you're actually.
Yes.
So that's aorta. Now you see that's IVC.
Yeah, IVC there.
Which way that's. IVC पे pulse Doppler लगा सकते हैं just to show. Yeah, there is IVC there.
Yeah, it's compressed.
That's IVC there. Otherwise, the other place where you get.
So now you can see it's a flat.
And we can also hear it better actually.
Yeah. Okay. But it seems much smaller. I mean, I think it's getting compressed again. So.
Okay, that's nice. Thank you.
Sure. So aorta again.
So now you're going clockwise.
Yes, clockwise.
And as you're going clockwise, you've got
the pancreas, uncinate, and then as I go counter, the duct comes into view. There's the pancreatic duct, and there's the bile duct above it. You see that, right?
Yes, we can clearly see both the ducts and interesting. What do you think is the reason here?
I'm trying to figure that out because the only question is there a subtle distal CBD stricture that we're not appreciating on EUS? His LFTs are normal.
Very interesting because the PD is really
dilated.
significantly dilated
Yeah.
and then just coming and beaking out.
Yeah.
Whereas you would expect if there was something there affecting both the ducts, you would expect the same in this view with the CBD as well.
Yeah.
Which you're not seeing, but I'm sure we haven't seen there's no mass lesion, there is nothing there, so interest possible. But what is surprising, and I'm looking at the D1 again, seeing how dilated is the CBD.
I'll show you.
And the ampulla look pretty normal, so
Yeah.
and normal LFTs.
And normal LFTs.
So what is the patient's complaint? Pain?
Epigastric pain, yeah.
So this is this.
I don't know if we have any amylase or lipase on him.
Sorry?
I don't know if we have a lipase or an amylase on him.
I'm pretty sure that should be normal. This is probably
Yeah.
chronic pain. This is not acute, is it?
To be honest, I don't know that component.
Could this
of
be
the issue.
something to do with ampullary sphincter pressure?
No, absolutely. I thought that doesn't exist in Pakistan. I thought that was the problem of the West.
No. We have all the problems.
Okay. We're just following the pancreatic duct and we're coming over the portal vein. You saw it.
So we saw the pancreatic duct all the way when he came
Yeah.
back.
And now we're just following it back. There's the pancreatic duct again. You can see it dilated. We're still in the stomach, and there it is
Oh, that's
going
nice.
downwards.
Beautiful pancreatic duct there.
Yeah, right. And then you can see here the bile duct below. Actually,
Yeah, there's the bile. Can you show it?
yeah. I'll put Doppler on for their advantage. So pancreatic duct, and below it.
And this is the bile duct. There it
Yes.
looks dilated.
Here it does. That's the thing. It does decrease in size as it reaches the papilla. But again, LFTs are normal.
Aapne,
I'll show you
what
a
does
bulb
the
view.
bile duct look like from the bulb?
I'll show you in a second. So we can follow it just for the audience. You can still follow it all the way back if you wanted to. There's the PD. There's a little cyst in the pancreas, by the way.
That's
You
the
can
PD
see,
there. That's the pancreas.
and there's a tiny little cyst. So
There's
these
a small cyst there.
anechoic lesions that sort of blink at you, they come into view. Look at my wrist movement. Just a little left, I lose it, go right.
The point I was making,
And so there you can.
slight movements and you've got the cyst, and if you don't have that movement, you miss that
Yeah.
cyst.
So you have a little cyst, you have the dilated PD, and
Slight
then
movement of the wrist, you get the cyst in the pancreas, and if you don't move it slowly enough, you're going to miss it.
so you can see how the PD all the way back to the tail
PD is dilated.
is dilated all the way back. Yeah.
So
So we'll go to the. I'll show you the bulb view again.
yeah, just.
Or you, I guess you haven't seen it.
No, we haven't seen the bile duct from the bulb. Just
Yeah.
a quick look there, and then we're done.
Yeah, except our candidate hasn't had the scope yet. But so my approach is basically get in across the bulb, and I usually turn my hand counterclockwise and drop my left hand. So I end up getting onto the liver right away, intentionally.
Okay.
And then I extend the big wheel and get even more counter, and basically I'm facing the floor. And when I do this, this actually wedges the scope in the bulb. And from here I do a bit of, these are multiple steps, but a bit of big wheel towards me and go clockwise. And this time of course we got right kidney, but invariably it brings me to the porta hepatis right about here. And with this I get my left, on the left of the screen you can see the porta hepatic node. Right there, and you'll have the bile duct here and then the pancreatic duct below it. So bile duct
Bile duct is dilated.
bile
here,
duct
right?
dilated here, right? So there's, and look at this portal vein is kind of prominent too.
Look, that,
So
what's that?
so there's the portal vein,
That's portal
bile
vein.
duct, hepatic artery. There's your three structures stacked together.
Right.
CBD, portal vein, hepatic artery, and there's the pancreatic duct.
ये
There's
जो आप देख रही हैं, ये
pancreas.
white मैंने नहीं देखा.
So as I come,
Can you just follow that duct and show us the duodenal fall off, please?
you want to see the endoscopic? Sorry, I missed it.
CBD?
They want to see the wall of the CBD. How to recognize CBD?
Yeah, these are. This is not. Yeah, this is not a stone.
There's, so by the way, let me just show you. Let's go ahead. This, you can see
Sorry,
this.
Mustafa, क्या बोल रहे हैं आप?
This is artifact from the probe. These white
Yeah,
lines.
Yeah.
And this is cystic duct and CBD. So you can see this little irregularity where the two ducts come together. And
Okay.
if I show it to you in real time, you can see the you can even see almost like a wall in between. So that's the CBD and cystic duct. And if I keep going counter from here, it'll take us to gallbladder. You see that's the gallbladder to the right of the screen. And if I unmag it and I change my small wheel left and right, or even go even more counter, I can see more of the gallbladder. And if I go clockwise again, I come back to the bile duct, the cursor is on the portal vein, and as I go clockwise, then it goes into the intrapancreatic portion here. I'm going to increase the size of my structures. And here, there's bile duct. It becomes narrowed there. There's the PD to the right of it. So bile duct, pancreatic duct. And there they come together into the duodenal folds which are here. The one thing you may want to sort of, you'll appreciate here is, you see this is dark and this is bright. This is ventral pancreas and this is dorsal pancreas.
Farooq, he's just showing the ventral and the dorsal pancreas.
Yeah, so this is ventral in cross section and this is dorsal in cross section. So you can see the bile duct always runs in the ventral pancreas. Sorry, this is the bile duct's here, that's the pancreatic duct. So one of the ways you can look for devisum, by the way, is if you come in from here, you can clearly see the two ducts coming together into the papilla there. These are duodenal folds up here. And as you follow the pancreatic duct, you keep following it. There's pancreatic duct, and it's gone over the portal vein, and now it's heading down towards the body tail, where the cursor is, that means that you've excluded divisum in this patient. So with a single hand, basically in the right position, you can do this maneuver and you can evaluate the pancreatic duct and the bile duct coming in and out. This actually gives us a very nice view of the CBD as it comes down. I think it is a sphincter-related issue. I don't see any obvious mass lesion from both the second portion or the bulb. But it's clearly a dilated pancreatic duct. Okay, there's the gallbladder again. So अब आप ऐसे करें, I want you to take
Can
over.
you share the contract of the trainee or the objectives of the trainee for this?
Yeah, the objective was for me to do the procedure and him to watch. I'm just kidding. I'm going to pass the scope. The objective was primarily, well, he was very generous and he said that he just wanted to look at some structures through the stomach. But I felt that given his experience, he should pass the echo endoscope down, which he did. And
This is pancreatic duct there looking in.
yeah, pancreatic duct there. And then
This is the neck of the pancreas going towards the head there.
our goal was for him to basically come to G junction, which he did already, for me to take a look at the structures, and then for him to identify at a minimum the abdominal portion of the pancreas and the body and tail. So I'm going to bring it back to the aorta and hand it to you, and then from here I'd like you to try and see if you can follow.
So, Mustafa,
Yes. Yes.
थोड़ी सी बेहतर. Why after this case is done, can we just report this, and so we can tell how you have reported this,
Sure.
and then also share your plan with us so that we can either criticize you or agree with you.
Plan for the patient or plan for the trainee?
Plan for the patient, because in the report you have to write that.
I'm happy to write that.
Yeah. So.
Here is the liver,
हाँ, पहले से
Yes.
बेहतर है. Thank you.
but
Yes.
I don't know what.
So
it
that
is.
was one of the
This
things
So-
we decided yesterday, right? So we want them to report so that we also get to know how you report. Okay?
Absolutely. This is the IVC. So if you pull back, this is the intrahepatic portion of the IVC. If you keep pulling back, it'll pull you, keep it in view, and so suction, it'll actually take you into the right atrium.
Suction.
Yeah, and if you keep pulling it, it'll bring you into the right atrium, into the mediastinum. Okay. So when you have that, when you have liver, if past the G junction, you see where you are now. You're in esophagus, right? So advance gently. Yeah, advance. So if you're too far, then get closer. Good. That's it. Keep going. You can look endoscopically.
Yeah, this is the liver.
Yeah. So keep going because you want to make sure you're in his stomach, right? Drop your left hand, right? Because you want to see where are we? Are we in? Drop some more and advance. There. So you can get hung up. So you have to drop your left hand. Now advance a tiny bit and now big wheel towards you. No, too much. Pull back. Big wheel towards you and go clockwise. That's the left lobe of the liver, right? And now keep spinning clockwise. So keep bringing your left hand up towards your face. And make sure you keep the thumb down. That's it. Keep coming, keep coming, keep coming, keep going, keep going, keep going, keep going, keep going, keep going. So you're getting glimpses of structures here. Keep going. So this was pancreas. Let's just see where you are. So I think we've come all the way around, but so that's you've come all the way to the left. You actually had left adrenal there, and you want to try and find either pancreas like what I was doing, or the alternative is to find aorta, which you're close to. This looks like aorta to me. So go back now. Go drop to the left. So there's that structure, arterial structure, right? So maybe pull back a tiny bit if you, because you intentionally went in deeper. Now pull back a tiny bit and repeat that same maneuver. Big wheel towards you and go clockwise with your left hand. Towards you, that's it. And keep going clockwise, keep going. That's it. Keep going. Keep going. Keep going. There you go. That's your aorta, right?
Yeah.
So now you've gone too far. So go counter. So other way. Counter is the other way. That's it. Now you have to go back. See, it's the little movement, right? Little movement to keep it in view. Okay.
Okay.
And now you have your cursor. Just stay there, okay? So this is your crust of the diaphragm. That's your aorta. If you have the crust, that means the celiac is slightly ahead, and you can actually see it coming off. So keep that aorta in view.
Okay.
So
aorta is in view, then what can we do?
now you can advance your scope very gently, keeping it in view. Advance it. Now if you lost your view, you have to go counter or clockwise to find it again. So it's not this way, right? So go the other way. And there you go. Okay, now relax your big wheel a tiny bit. Just relax your big wheel and then advance. There. And now go counter. Other way. Other way. Other way. Other way. Other way. Keep going counter. Keep going. There you go. You see your celiac take off? So that's excellent. So go. Now you lost it already. So bring in the celiac. This beautiful. So you just brought in the celiac artery and the SMA into place. Okay. But you see how little movements are making such a big difference in you being able to see what you want to see and you don't want to see. So my way of looking for adrenal usually is once I have the celiac in view, I will go clockwise 90 degrees. So thumb down a bit and go clockwise. So you're getting gastric I think here.
Yes.
Yes.
So that was nice because he's actually shown you celiac artery and aorta pretty well, and we've seen liver.
Yeah, absolutely.
So
he's gonna show us pancreas next.
Okay, good.
Yeah. I don't know if it's the
should
student
go
or the
down.
teacher, but we're doing really well here. So drop your left hand.
I said good to the student.
Good. I agree with you. Okay, advance a tiny bit and suction. Advance. There. Stop. Suction. 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 Okay. Now big wheel towards you and go clockwise again. And if you don't find pancreas, then what you do is you. So you have that celiac.
So you've got
again,
the
right?
splenic vessels there, so
Yes.
you just need to.
Yeah, so just advance a tiny bit. One thing I want to make you look at, when you go clockwise too far, then you go
We
back
need to-
towards fundus.
So, so one of the things that I
Section,
noticed when I was
section,
learning
section,
early
section.
is that
Don't
our
learn it.
habit is to keep our finger on the air.
Yeah. there you
Okay,
go.
that's
your
our
pancreas.
natural habit as endoscopists,
Yeah,
and that's what we need to avoid when we're doing EUS,
yeah.
because air is actually going to make life. So you've got pancreas now.
We have pancreas. This is your duct. So if something is to your right, if you
That's the
slowly
pancreatic duct.
if you slowly pull the scope towards you, that'll move that object towards the middle. You see that? Very nice. Now if you now your goal is to keep the duct in this area and follow it towards the tail this way and towards the head that way.
So if you go clockwise
so-
from here, you're going to go to spleen.
Yeah.
Okay,
You go clockwise. There
you're
you
going
go.
to
Good.
see kidney and spleen. If you go anti-clockwise,
Now
you're going to
you-
go towards the neck.
So there you go. Now go the
And
go the
that's-
other
you've
way.
got the kidney
So
there.
now it's falling away from you, right?
Yeah.
In that situation, you have to advance it. You have
That's
your
the left adrenal there.
Yeah. So that's it. Advance. And now relax your big wheel. There's your PD again.
Yeah, this is the
That's a nice PD.
Yeah, exactly. And then go relax your big wheel and go counter some more.
Okay.
Okay.
So
Uh-huh.
if the objectives of your session are done, then we can
Yeah, we can move on.
we can move on now. If you could just report it so that we discuss that.
Sure.
And with the trainee, and then you can either read it out or I'll ask them to focus the camera on that. Okay.
Okay, sure.
Thank you.
Sure, you're welcome. Sir, आपका टाइम का मिला है? We will मैं निकालते मैं आपको मेरे चैनल दिखा दूँ एक मिनट बस. इसको ऑफ करना है कर से. Thank you.
And this is also
तो basically हाँ जी कर दें. So left atrium.
So you can
Left
nicely see the
ventricle.
mitral valve there,
Yeah.
Sorry, I'm just going to make it
aortic
smaller.
valve there.
Yeah, aortic valve.
That's the mitral valve.
So that's going to be our.
So left atrium.
So those are the subcarinal lymph nodes. You can see them
So
right
those
next
are
to
the
the
normal
probe.
looking subcarinal lymph nodes. You'll see them anyway.
And then you can follow the aortic arch if you want. Sorry, aorta to the aortic arch. There's a trachea. You can see the trachea is causing artifact now. So you can spin, and there's your aorta, and then the
That's
left
the AP window.
AP window, and then so the way I was
Very,
Yeah,
very
aorta.
get to, okay,
This is aorta.
नहीं, ये
yeah,
तो नहीं।
aorta left
ये
pulmonary
तो
artery.
vessel होगी, I'm sure.
ठीक है? Okay.
Thank you, Mustafa.
Yes.
Can we get the next patient apna ready and?
How would you like me to do the report? Because I
No,
think
no.
it's
I
best in
would
the-
I would want you to do the report. We have a system in our unit. If you're comfortable, you do it that way, and
Yes.
they will just show it to you, Wasim. Patient की report को निकाल दो screen पे, and once you're done, then you just let the guys there, media guys there, who will then focus at the report, and we can see it.